Good evening, everyone, and thank you for taking a little bit of time this evening to talk about a topic that is on everyone's mind in parenting and managing young athletes, which is the topic of ACL tears. I'm going to talk to you a little bit about ACL tears, soup to nuts, but I'm going to spend a fair amount of time at the end talking about the most important topic, which is how to prevent these injuries from occurring in the first place. But first, a brief word about the anatomy of the ACL. The ACL is one of the cruciate ligaments of the knee, and it's so called because it crosses the middle of the knee in a diagonal fashion, together with the other cruciate, the PCL. You also have collateral ligaments on either side of the knee, the lateral collateral on the outer part of the knee, and the medial collateral on the inner part of the knee, both which participate in stabilizing the knee and preventing the knee from bending sideways. And finally, we have the meniscus. We have the outer meniscus, or the lateral, and the medial meniscus, the one on the inner part of the knee. And these are the C-shaped rubbery discs, or wedges of tissue, that sit between the tibia and the femur in the knee joint. And they serve multiple roles. They serve as a shock absorber. They serve to allow the relatively round femur to fit against the flat tibia better. And they serve to distribute force more broadly across the joint surface to prevent premature arthritis. But it's the ACL, the anterior cruciate ligament, that we're going to be talking about today. Even though we talk about the ACL as a singular structure, what we've learned over years of anatomical research is that the ACL actually consists of two bundles, the posterolateral bundle and the anteromedial bundle. And you can see them here in these illustrations. And these bundles actually work in concert as the knee moves from flexion to extension to stabilize the knee during cutting and pivoting activities. And the ACL has multiple different roles. I think its primary role is from preventing the knee from translating too far to the front. And you can look at the side view and see how the ACL runs in a diagonal fashion from back to front, so that when the tibia bone, or the lower leg bone, wants to translate forwards, the ACL serves as a check ring. The ACL also importantly serves to provide rotational stability to the knee. And again, you can see looking at the front of the knee that the ACL runs in a diagonal direction. And because of this orientation, it can help the knee to stabilize and prevent the tibia from rotating excessively relative to the femur. And finally, the ACL helps other ligaments do their job. I mentioned earlier that the collateral ligaments run on either side of the knee and prevent the knee from bending sideways. And the ACL serves as a secondary stabilizer to what we call varus and valgus stress. It helps the collateral ligaments do their work. And that's why sometimes in high energy injuries, these ligament tears often happen together. The ACL is a very strong, stout ligament. Its ultimate tensile load before it fails is more than 2,000 newtons. And our activities of daily living don't really even come close to this amount of force. Passive movement of the knee only exerts about 100 newtons on the ACL, and walking only exerts about 400 newtons on the ACL. But it's with cutting activities and those that require rapid acceleration and deceleration that start to stress the ACL a little bit more. Cutting and acceleration can exert about 1,700 newtons on a normal ACL. And with even more energy, the failure capacity of the ACL is exceeded. This often occurs during combined movements, and the ACL can eventually tear. These ACL tears are exceedingly common. There are about 200,000 ACL injuries each year, and at least 100,000 of these patients undergo reconstruction. And this accounts for about $1.5 billion of healthcare costs associated with the surgical management of ACL tears. Now, most of these injuries occur during sports, about 70% of them. And what most people don't realize is that the vast majority of ACL tears are non-contact injuries. It's only a small minority of tears that occur when one player hits another player's knee. And in general, it's rapid and unanticipated change of direction that leads to these non-contact injuries. There's a very characteristic pattern of injury that occurs with the ACL. we first have to consider body position, which is illustrated in this photograph. Typically, the hip is internally rotated and adducted or brought towards the midline, and the knee is often near full extension, while the lower leg is externally rotated. The forces that are exerted on the ACL occur because the foot is planted and again rotated outwards, and the body is rapidly decelerating or slowing down. And this exerts what we call dynamic valgus to the knee. You can see here that the knee wants to buckle inwards and rotate. And this dangerous dynamic valgus force is what most often causes a non-contact ACL tear. When we look at the common culprits for ACL tears with regard to sport, they're the sports that we commonly think about: soccer, football, basketball, lacrosse. But what many people don't realize is that women suffer about 2 to 8 times more ACL injuries compared to men in the same sport. If you look at this graph, you see that the first 3 out of 4 sports with the highest incidence of ACL injury per 100,000 athlete exposures are the female team sports. Girls soccer and basketball are the most notorious culprits, and it's important to try to understand why these young women are at higher risk for ACL tears. And there are a variety of risk factors to consider. Some of them are universal, and others may apply more to young women than to young men. One of the universal risk factors is the environment, and this has most to do with the torsional resistance that occurs when your foot meets the ground. The 2 factors to consider here are your cleats or boots and the playing surface upon which the sport is taking place. The higher number of cleats and the deeper cleats will increase friction between your foot and the turf. So athletes are often making a trade-off between traction and being able to change direction rapidly and the importance of avoiding ACL and other ligament tears. The playing surface is also important. Natural grass is typically safer than most artificial turf surfaces, although the most modern generation of field turf has become better at decreasing the torsional resistance between your foot and the ground. There are many anatomical factors that have been proposed as important when talking about ACL tears and may begin to explain the differences between men and women. First is notch width. The notch is the space in the middle of the knee where the cruciate ligaments attach. And intuitively, the more narrow the notch, the perhaps more likely a patient is to sustain an ACL tear. And there are some studies that describe a more narrow notch among our young female athletes. Generalized joint laxity is also important, and we can assess joint laxity, which is another way to describe how tight or loose our connective tissues are, by looking at a variety of things: whether our elbows bend past straight, whether we can touch our thumbs to our forearms, whether our fingers hyperextend, whether we can touch our palms to the floor with our knees straight, and finally, knee recurvatum, or the ability of the knee to hyperextend. All of these indicate generalized joint laxity, and joint laxity has been proposed as a risk factor for ACL. And it's that knee recurvatum, or that knee hyperextension among young female athletes, that most significantly increases their risk of an ACL tear. What's also important is the microscopic architecture of the ACL. When you look under a microscope, there actually are differences between ACL ligaments among young men and young women. Young men tend to have more ACL fibrils per surface area, and these fibrils tend to be larger than their female counterparts. And this also may help to explain at least some of the differences between young men and young women. Hormonal factors have been looked at in a variety of studies, and there are actual hormonal receptors on ACL tissue itself, the blood vessels that supply the ACL, and the synovial membrane that wraps around the ACL. And there has been demonstrated some difference in how strong the ACL is depending on when in the menstrual cycle you examine it. So although it can be controversial, hormonal factors have been proposed as a possible source of the difference in incidence of ACL tears among young male and female athletes. One of the most important modifiable factors in talking about the risk of ACL tears are the biomechanical and neuromuscular factors. There are a variety of differences between young male and female athletes. What we know is that decreased recruitment of your buttock muscles or your gluteal muscles, decreased recruitment of your hamstring muscles, and increased recruitment of your quadriceps all can increase the risk of ACL tears during sport activities. And again, that increased dynamic knee valgus is incredibly important. And all of these things have been shown to occur more often among young female athletes. And perhaps this can be a target of pre-injury preventative strategies. And we'll talk more about that in a moment. The occurrence of an ACL tear is not subtle. The history often gives it away. Young patients will often clearly describe the mechanism, what actually happened on the field at the time of the injury. They oftentimes will feel or hear a pop or tear, and they'll have a giving away or a buckling of the knee. The knee simply cannot maintain stability when they try to change direction or sometimes even take a step. When we examine them in the office or on the field during sideline care, there are several tests we use to assess the ACL. Two of them, the anterior drawer test and the Lachman maneuver, are similar. We essentially try to translate the lower leg bone, the tibia, anteriorly or towards the front relative to the femur. The left is the anterior drawer test, the right is the Lachman maneuver, and we grade how far the tibia moves relative to the femur. And importantly, we compare it to the other side because every patient is a little bit different with regard to their normal laxity. And if the tibia translates too much, that is suggestive of an ACL tear. We also pay attention not just to how much it translates, but whether there's a firm or a soft endpoint. In a normal patient's knee, the endpoint is firm like a brick wall because that ligament is intact. It's serving as a check rein. When the ACL is torn, that endpoint is more soft or doughy because that ACL is no longer doing its work. The pivot shift is another test we perform. This one is a little bit more difficult to perform in a patient who's painful, but what we're trying to do here is examine that important role of the ACL to provide rotational stability. We exert a little bit of rotation to the lower leg bone, the tibia bone relative to the femur, and we bring the knee from extension to flexion, and we actually watch as the tibia moves from a slightly dislocated position to a reduced or more normal position. A normal knee will be a smooth glide. It'll be relatively unremarkable. And an ACL torn knee will have a clunk or a jump or even a transient lock as that tibia tries to jump back into its more normal position. MRIs are our test of choice for definitively diagnosing an ACL tear to confirm our suspicion based on the history and the examination. And there are a variety of signs we look for. The obvious one on the top left panel is discontinuity or separation between the two stumps of the ACL. Looking from the front, the bottom left panel will show an empty notch where the ACL should attach to the femur. In a more chronic case, the ACL actually tends to resorb. It fades away over time as it's bathed in the normal joint fluid. So chronic tears will present actually with absent ACL tissue altogether. But without even seeing the ACL, with looking at other parts of the knee on the MRI, we can guess that an ACL tear has occurred. If you look at the right panel, we don't even see where the ACL is, but we see a characteristic bone bruise pattern. You see that there's whiteness in the femur bone at the mid portion, and there's whiteness in the back portion of the tibia. And what this demonstrates is that when this injury sustained an ACL tear, the bones twisted, they then banged against each other, which allowed the middle part of the femur to bang against the back part of the tibia and create this very characteristic bone bruising pattern that tells us that this patient likely sustained an ACL tear. Importantly, we have to consider other injuries. It's very common to have an ACL tear and other injuries as well. The meniscus is the most common, and either the lateral meniscus or the medial meniscus can be torn in these patients, and hard to diagnose on an examination of a painful swollen knee, but these meniscal tears will show up on an MRI and will impact our treatment strategy. Other ligaments also can tear quite commonly with the ACL. About 20% of ACL tears will come along with an MCL tear. Again, we talked about how these ligaments work together to stabilize the knee. And when that MCL tears, again, it's going to impact how we manage these patients. And finally, in certain cases, that precious, smooth, pearly white joint surface cartilage that caps the end of the bones at the joint level can be damaged during the event that also tore the ACL. And it's very important to identify these cartilage injuries and incorporate them into our treatment plan. When we take all of this together, what are the reasons that we operate on an ACL? What are our surgical indications? Well, first and foremost, certain patients simply can't walk or change direction during normal everyday activities without their ACL. So we operate on the ACL to restore function. For our young athletes, the topic of this talk, it's extremely difficult, if not impossible, to return to cutting and pivoting sports without that ACL, and replacing it or reconstructing it is often the only way to get them back to sports at their same level. We also operate to address those other injuries that occur at the same time as the ACL, those meniscal tears and cartilage lesions. And if an ACL tear occurs in conjunction with another ligament, the MCL, for example, or the PCL, that often requires surgery for that reason alone. We operate on the ACL also in order to protect the meniscus from further damage. What we know about an ACL deficient knee is that as a young athlete continues to play and live on that ACL deficient knee, they're much more likely to sustain an injury to that meniscus in the future. And by the time we get to that meniscus, repair is often much more difficult to deal with than preventing the meniscal tear to begin with. And finally, in these young patients, we operate on the ACL theoretically to protect them from future arthritis. It makes sense that if an ACL deficient knee is likely to develop a meniscal tear and a knee with a meniscal tear is more likely to develop arthritis, that interfering with that upstream event, preventing that ACL tear from tearing in the first place or replacing it when it has torn, may protect that patient from arthritis in the future, although this is a theoretical benefit and we haven't yet demonstrated conclusively that we are able to do this. Once we've decided to operate on the ACL torn knee, we then have to talk with the patient and their family about when surgery is going to occur. You may notice with athletes that you watch on TV or root for that it's very rare to have an ACL surgery immediately after the tear occurs. We often allow a little bit of time before surgery, and there's good reason for this. If we operate on a knee that's very painful and swollen prematurely, we are likely to make that situation worse. Patients can develop scar tissue, or what we call arthrofibrosis, which can lead to long-term or permanent motion loss and prolonged weakness of the quadriceps. So we would much rather prefer to allow a little bit of time for the swelling to resolve, for the patient to regain their motion, and for the inflammation to subside, and then operate on the knee in the optimal situation. And this can take a few weeks to get to that point. We often send our patients to presurgical rehabilitation to help with this. The therapist will use some modalities to decrease swelling and inflammation. They'll also do some gentle range of motion exercises, particularly to achieve full straightness, which is the most important direction to achieve before surgery. And then they'll work on strengthening exercises to re-engage the quadriceps muscle so that their post-operative rehab can be easier and quicker. This is an example of one way we do this operation, a way that's commonly used, where we use a targeting device to drill a socket in the bone. We first use the targeting device to place this thin guide wire, and once we're satisfied with the placement, the tip of the guide wire actually flips on itself and becomes a reamer, and we can use that reamer to create a socket of the appropriate depth and diameter to fit our graft. We then place these shuttling stitches in both sockets, and we use these shuttling stitches to shuttle the graft into each socket, one socket in the femur and one socket below in the tibia. And we fix the graft in each socket after tightening the graft by placing these small titanium buttons and securing the loop of very strong suture material over these buttons. It's sort of like an anchor of a ship. It serves to anchor the graft on the femoral side, and it serves to anchor the graft on the tibial side in order to provide secure fixation while the graft incorporates during recovery. And that's what the graft looks like after surgery. The main decision point for families and patients with the help of your surgeon is what type of graft to use when you do this operation. There are a few different options. In general, though, we want to choose a graft that has the structural properties similar or stronger than your normal ACL. We want to be able to secure the graft with very strong fixation to withstand the forces of rehab and ultimate return to sport. We want the graft to incorporate as fast as possible. And when we take this graft, we don't want to, we want to minimize what we call graft site morbidity, or the downside to the knee when we take this tissue. One option is cadaver graft, what we call allograft. And this is appealing because you're not taking it from your own knee, and therefore the graft site morbidity is basically zero. However, the disadvantages of allograft are that it has a slower incorporation, and in the literature, it has been demonstrated to have a higher re-tear rate. So we try to avoid cadaver grafts in our young athletic population. We tend to reserve these grafts for our lower demand patients, patients undergoing revision surgery where they might have already had their own tissue used, or in surgery where we need multiple grafts in the case of a multi-ligament knee injury, for example. We tend to prefer autografts in our young athletes for the reasons of healing time and re-rupture risk. And the most commonly used is the patellar tendon. This is a graft where we take the central 1/3 of your patellar tendon with a piece of bone on either side. And because you've got this bone on either side, there's theoretically bone-to-bone healing, which we think is advantageous. We tend to use these grafts in our higher demand patients and in our collision and contact athletes, and perhaps it allows a little bit of a quicker return to play. Maybe the one downside of patellar tendon graft is the slightly increased incidence of kneeling pain with this graft, so we have to keep in mind the lifestyle activities and the sports requirements of our athletes, and we counsel them about this risk. Hamstring is another frequently used graft, and it can be a workhorse because it really does optimize a lot of the concerns we've talked about. It minimizes graft site morbidity because we're taking only one or maybe two of your hamstrings, and it does not seem to lead to significant hamstring weakness. We harvest the graft from the back in a small incision, so it can be cosmetically appealing, and it does certainly provide the strength that we need to allow patients to return to sport even at an elite level. We tend to use these for recreational athletes. We also tend to use these for our skeletally immature patients where we want to use an all soft tissue graft since it doesn't have the bone plug on either side. A graft that patients and families may hear more about in the years to come is quadriceps. It's less commonly used than the patellar tendon graft or hamstring because it has less of a track record, and perhaps that's the primary disadvantage. The literature is evolving, although it certainly has the biomechanical properties that satisfy the criteria for the ACL, and it certainly has demonstrated early results that are acceptable. The benefits are that it reduces the harvest morbidity associated with the patellar tendon, and it allows you to harvest a larger graft for our competitive athletes. So this may be a graft that increases in popularity over time as literature is published about its long-term results. I wanted to briefly address the growth plate. I often have families with young patients approach me with an ACL tear and assume that just because the growth plate is open, they must have a growth plate avoiding operation. And that's not necessarily true. But before talking about this, I just wanted to explain a little bit about the different surgeries we do for our young patients. We tend to divide these surgeries into growth plate sparing operations that don't affect the growth plate or growth plate respecting operations. The sparing operations can either be done by completely avoiding the drilling of any tunnels and simply wrapping graft material in the general area where the native ACL lives. That's called an extra-articular graft, and because it's not necessarily anatomical, is really reserved for our absolute youngest patients who are at significant risk for growth plate disturbance. We also have the growth plate all epiphyseal technique. This is one in which we do drill tunnels, but we try to position these tunnels to stay away from the growth plates. As you can see in the middle panel, And this is also suitable for our younger patients where we really don't want to affect the growth plate at all. But to be honest, for many of our young patients, because most of their growth is completed, we can drill across the growth plate. We just have to perform what we call a growth plate respecting operation. We try to create tunnels that are more vertical as opposed to being oblique. We try to use soft tissue grafts so that a bone plug is not sitting across the growth plate. And we try to use fixation techniques like these buttons that are remote from the growth plate rather than a screw that crosses the growth plate. And by respecting the growth plate, we can give the patient as anatomical a procedure as possible while minimizing the risk of growth plate disturbance. And the factors that we use to decide which operation is ideal for the specific patient has to do with where they are in their skeletal maturity. We talk to the patient and their families about when they had their peak velocity of growth, how tall are their parents and siblings, where they are in puberty, and when they might have experienced their first menstrual cycle. All of these are important in deciding what type of operation our skeletally immature patients require. Another quick word about ACL repair. It's something, again, you may hear more and more about in the coming years. It has received increasing attention in the literature, and there are some studies that propose that it is a good operation for certain patients. In this situation, instead of reconstructing the ACL, where we replace the torn ACL with new graft tissue, with ACL repair, you simply repair the normal ACL back to its attachment site with a series of sutures and buttons. What I would say about ACL repair is that if it's going to be performed, it is really appropriate only for a very, very small subset of patients. And these tend to be patients where, first of all, they may be very young, where their biology is optimal. They may have torn the ACL directly off of its femoral origin, where it attaches to the notch. And the tissue itself has to be of good health or of good quality. And if all of those criteria are met after a lengthy conversation with the patient and their family, perhaps an ACL repair could be considered, although certainly an ACL reconstruction is still the gold standard. But the point of this talk is really to avoid any of these questions altogether. If there was a way to avoid the tear from occurring to begin with, that is an enormous win, because these tears really do take a tremendous toll on our young patients. It's at least 6 months out of sports. Certainly interferes also with their ability to participate in school activities. There's obviously pain and disability involved with the operation, and there's a risk of re-tear in the future and a risk that they may not be able to return to sport at the same level in certain instances. So we want to try to avoid these tears from occurring to begin with if we can. We've talked about the problem of biomechanics and neuromuscular control in our young patients, particularly in our young women. There are deficiencies in muscle strength and coordination. There's poor muscular control of the hip and knee joints. There's more activation of the quad relative to the hamstring, and there's more of that dynamic knee valgus that tends to exert shear force and rotational force on the ACL and often lead to a tear. The solution seems to be an ACL injury prevention program, and the purpose of these various programs, and there certainly are many that are out there now, is to target abnormal movement patterns at the hip and knee, to improve strength and agility, provide plyometric exercises that our young athletes can perform, to improve their cutting and pivoting techniques, to improve their jumping and landing techniques to avoid that dynamic knee valgus. The newer programs will also incorporate perfecting falling techniques, believe it or not, to try to keep these kids out of those problematic situations, and to avoid high-risk positions in unpredictable situations during the heat of competition. There are a variety of them out there, as I've mentioned. What we know is that many of these have been proven to improve motor control, balance, and agility of these athletes, and some of them, including the FIFA program, have demonstrated up to a 50% reduction in ACL injury risk. What is true is it's most effective in certain sports, including soccer, but is somewhat effective across the board. It's most effective in our youngest patients. And it's only effective if it's begun in the preseason and if it's consistently implemented throughout the season and year after year by our young athletes. One example that is proven in the literature to be effective is the FIFA 11 Plus for kids. And this began as a program of 11 exercises for our older athletes at higher levels of competition, and it's been modified for young children. And it basically consists of 7 exercises that can be performed along a spectrum of experience from beginner to advanced. And you perform several repetitions of these exercises under the supervision of your coach and advance through the progression of experience over time. It takes about 15 minutes to perform, and it can be incorporated as part of a warm-up or as a dedicated set of exercises to be done 2 to 3 times per week. And again, it has been shown to significantly reduce the incidence of ACL tears among young soccer players in particular. So in summary, the incidence of ACL tears continue to rise, particularly among our young female athletes, and there are a variety of reasons for this, but the most important modifiable reason are the biomechanical and neuromuscular differences that seem to exist between young men and young women. Unfortunately, the ACL, once it fully tears, will not heal on its own and often requires reconstruction in order to stabilize the knee and return that child to their sport and to their life at their same level of participation. But the good news is that, as I've said, prevention programs are easily implemented and can certainly effectively reduce the risk of ACL tears among these patients. So thanks again for taking this time to learn a little bit about what we can do to prevent this important injury.